topic has been chosen with something in mind, specific in our mind. So first of all, I'd like to introduce myself. I am working with Birla Fertility and IVF. I'm their head medical services at Delhi. So before I start, a very warm welcome to all of you. I mean, having 9,600 people before we start the class itself is it's very, very heartening. And I'm so grateful for all of you who have joined us. Somebody can erase those green lines from the screen. Otherwise, I won't be able to write. I'll be so grateful. Pooja, can you check who wrote on the screen? So it's a very commercial world. The pharmacotherapy, the clinical therapy is a commercial world. Whenever you speak about a topic, you always feel here, what is happening? Is it pharma driven? So ICIT is never pharma driven. ICIT has got no correlation with any pharma. What I want to talk with you today, I'm not selling a drug. Not at all. I have never done it in my life, and all my students know it. So why we chose this topic? So why did we pick up a topic of LPS? Very common topic, and it's like we are cooking something, we don't know the ingredients. So luteal phase is basically equal to progesterones which are acting under effect of LH. This is what you have to just know. So this child is baby like probably my childhood picture, long time back. So any baby which was born somewhere in before 1995 or 1990 was from the black and white era, I say that. And this is probably majority of you, young people, full of color and life, bright, smiling, and sparkling eyes, and they're all progesterone babies. Somehow we've been driven by the whole of companies that no baby is born today without progesterone. Like folic acid, we keep writing some progesterone to them. Probably the new generation is very bright. My understanding is that luteal phase deficiency is something like, my screen sharing is paused. Just give me 1 sec. I'll start. Fine. So the luteal phase defect. Gone back to. I request someone not to touch the controls, because if someone touches the controls, I lose my control. So please don't use your pen or hand to write on the screen. So when we look at this thing, we are talking about the luteal phase support or the luteal phase deficiency. So there are multiple ways the luteal phase defect can alter the pregnancy outcome. There can be difficulty in conception, there can be recurrent pregnancy losses, preterm labor, threatened abortions. But we'll be today focusing on luteal phase in ART only. That will be my the point of contention. We'll talk about a luteal phase defect in ART only. And now when we move further, we find that this is a very nice article which I found. This is dated 2018. And immediately when the class is over, I'm going to send you this thing on your WhatsApp. You'll all get this beautiful piece of literature. It's from Israel, and so it goes beyond the doubt that it's going to be very, very nice. And this will sum up all your queries about IVF. One more beautiful book which I say people to read is Gardner. In case you have time, read from Gardner. It talks very beautifully about luteal phase support. Well, we're covering my talk under the following headings. First of all, we'll talk about the physiology of menstruation. We'll talk about understanding the luteal phase and its defects, and how ART disrupts luteal phase. Both IUI and IVF can disrupt luteal phase, and we're going to talk about that. And what type of progesterones we have to give to the patient, we'll talk about them also. So now, moving ahead, what is a luteal phase? We talk about luteal phase. Luteal phase क्या होता है? It is a period between the onset of the ovulation, when the lady ovulates, whenever she ovulates, and the onset of her periods or pregnancy confirmation. This is the period which we call as the luteal phase in a woman. We're finding that this luteal phase is becoming weaker due to certain reasons about which we will talk. So we are talking today, we're going to learn about how to support this luteal phase deficiency. So this what we learned some time back. This definition came in 1991, a lovely definition. In case progesterone levels, P4 levels are less than 10 nanograms per ml, we say the mid-luteal phase progesterone are less than 10 nanograms per ml. We say the lady has got luteal phase defect. That's a definition which came out initially. And there are multiple reasons of these things written here. You all know about it, but today we're going to talk about ART, how ART disrupts the luteal phase defect. This again, a very nice thing I found, and in case you look at it, we talk about P4 all the time. We talk about P4, but here we'll talk about LH. LH will always act upon the corpus luteum, and P4 will come from the corpus luteum. So in case you look at the mid-luteal LH levels, we can come to know that the levels of progesterones may be bad, because LH will keep coming in these pulsatile waves and acting upon the Cl, and Cl will produce P4. In a natural cycle, the LH in the mid cycle, as you can see here, in case you look at the LH values, mid-luteal, it will be around 6 in a natural cycle, with P4 of 10. It will be 1.5 in case we give a GnRH trigger to a patient, and in case we give HCG trigger, it will be 0.2. I'm going to send you this article also in some time, so don't worry about these numbers. You'll get this article within 10 minutes of the lecture being over. But you must read about these two slides. Read about this and read about this. This is very, very important. So, coming to the physiology of menstrual cycle. This figure we have seen many times, and we know that there is something called hypothalamus-pituitary axis from which LH comes. It acts upon the follicle becomes bigger, follicle will secrete estradiol, and the estradiol is going to bring LH. When the estradiol will bring the LH, then the LH will cause, LH is a villain probably, it's going to rupture the follicle and the egg comes out, and egg can be fertilized or it may not be fertilized, and this corpus luteum will become corpus albicans, and finally it will veer off in case there is no pregnancy. But this corpus luteum is being maintained by the LH. This you have to know, that the biggest challenge in the whole of ART is controlling the LH. In case they ask me, I have put in around 18 years or 19 years in active IVF, I'm not talking about IUI, that must be around 25 years, that in case we have to control one villain, that is the LH. So something about the menstrual cycle, as you can see that this is day 14, and day 14 we are having the ovulation, and before ovulation we are controlled by the estrogens, and after ovulation comes progesterone, and it comes from the corpus luteum. Just remember this figure is going to take you in a big way. It's going to help you as you move forward, and you'll find that for ovulation to occur, we need an LH peak. So LH peak is around 22 MIOs per ml. This is what an LH kit will detect. When good LH peak comes, the figures will touch, we'll have to get two lines, and the values may go, that midday values may go to 22. And then when LH peaks, then LH will fall down, and then LH will keep, after peaking, it will go like this. And this will maintain the corpus luteum. So LH role is not only ovulation, but also maintaining a corpus luteum. And this is another figure which shows that, as you can see here, that we have a play of hormones occurring, and we need to understand that as these things are moving ahead, this is the LH. This is the LH, and this LH will peak here, and after that the LH is going to fall down gradually. LH will come to these values, but they're always there, and then with LH we will get progesterone. So LH and progesterone are good friends. When LH is bad, progesterone levels are also bad. Understanding the physiology of corpus luteal function, there are two parts of this, granulosa cells and the theca cells. And this I have actually never understood. Whole life I have tried to read a book called Prof, and still I draw blank here. I just draw blank here. I'm sure majority of you will also be like me. And there are multiple theories, two cell theories, which occurs before ovulation, post ovulation. These theories continue. But one thing we have to just know is that from corpus luteum, which contains theca and granulosa cells, we will be getting progesterones in the post ovulatory period or the luteal phase के अंदर हमको progesterone मिलेगा blood के अंदर. This you have to know. So post ovulation progesterone is being secreted by the corpus luteum. I am, for some people who are joining late, I would like to say that after the follicle ovulates like this, the egg comes out. This happens under effect of LH, and LH will keep acting upon the corpus luteum. This egg may be fertilized or non-fertilized. It's a different issue, but LH will keep coming and acting upon the corpus luteum. And the corpus luteum, looking at this figure, this is a corpus luteum, it will keep secreting progesterone. So when we have some deficiency of LH, when the LH is poor, or when the P4 is poor, then we have luteal phase defect. This is what you have to understand. So as we can see here, if no fertilization occurs, the egg will go and the LH corpus luteum will degenerate, and then we'll have corpus albicans. So this is the way the whole thing is moving. One thing which nobody actually understands is that we talk about LH peak, but what does LH do? Why is LH so important for us? LH is the biggest villain. The biggest villain is the LH, and the biggest friend is LH. In case we have premature surges of LH coming before ovulation, LH is a villain. But in case there is no LH, then there can't be any fertilization. And it's not only that LH acts upon the corpus luteum, but LH will also act upon the endometrium. LH is a friend of endometrium, and in case there is no LH, endometrium is of poor quality. So when the follicle starts growing up, it will bring out estradiol, and this estradiol is going to bring LH, and when LH comes, it brings progesterone from the corpus luteum. And even more important is that LH, as it's peaking, will act upon the blood vessels, and the blood vessels will start becoming tertiary blood vessels, and it will make endometrium okay for implantation. So as you can see here, under the effect of LH, we are having blood vessel proliferation. So without LH, we actually cannot move ahead. So take home message. I'll keep popping in small take home messages for all of you who are joining me. You have to understand that LH ovulation is induced by mid-cycle LH surge. When the mid-cycle LH comes under effect of estradiol, that's the time when the corpus luteum is going to be formed and ovulation will occur. Luteinized cells will form corpus luteum here, will form a corpus luteum here, and they start making progesterone, which is P4. This thing should be clear to you. The corpus luteum is always being controlled by the waves of LH. In case the waves go bad, first of all, is LH is not there, then there's a problem, big problem. And when the LH, good amount of waves are not there, then again corpus luteum is of poor quality, and there would be a luteal phase defect. So what does a normal luteal function require? Normally क्या होना चाहिए हमारे corpus luteum के अंदर? we have to know that we have to have a continuous surge of LH coming like this. And then estrogen will induce progesterone in the endometrium. And then those cells will start making progesterone under effect of LH. And LH will not only make P4, it will also act upon the blood vessels. This is what you have to remember. That will act upon the blood vessels also. So in case when we look at the endometrium, before implantation, we do some zonal vascularity studies. We say zone 1, zone 2, zone 3. हम बात करते हैं. You may be aware of this. How's the blood supply to the endometrium? Nowadays, we are doing zoning of the endometrium before every embryo transfer. And we can say endometrium is 9 millimeter, 10 millimeter, beautiful endometrium, but there is no blood supply. There is no blood supply. This means that there is at some point of time LH deficiency. And then LH deficiency will mean finally we'll also have progesterone deficiency. You see, there are a few things which I have learned like this. So for good outcome, we have to have developing follicle, which should form a corpus luteum under effect of hormones of anterior pituitary. So why is progesterone so important for us? It is important because in case it is not there, then there can be these things coming. It can be luteal phase defect in ART, poor pregnancy rate, RPL, preterm labor, threatened abortion, and all these things can occur. Now, when we prepare, when we see the LH is important and progesterone is important, it is important to make the endometrium secretory and to make the endometrium vascular. So we normally are always looking at the endometrium. When you look at the endometrium, we say that endometrium has got triple layer endometrium. We look at the endometrium like this and we say endometrium is triple layer, 9 millimeter. We'll do IUI or we'll do embryo transfer. Don't do it. Always do the zoning of the blood vessel, zone 1, zone 2, zone 3. Till the time the blood is not coming to zone 3, avoid doing the embryo transfer. So it will mediate cellular immunity. It mediates a uterine blood flow, uterine endothelial adaptation to the pregnancy by increasing nitric oxide production. These are all few theoretical things which I will just try to give some insights and move ahead. That a progesterone is a relaxant. Whenever you give somebody progesterone, what happens to that woman? Would anyone like to say what happens when you give somebody progesterone or you take a tablet of progesterone yourself? What happens to? What is the common side effect of progesterone? Can anyone tell me?
Nausea.
Something more than nausea?
Giddiness.
Fatigue and sleepiness.
Headache, tension, this tension.
Sleepiness.
This tension, less peristalsis.
So hypotension.
Hypotension.
Warm feeling.
Bloated up.
Bloating and distension.
Edema, swelling of the bloating.
Mainly it's hypertension.
Sleepiness.
Warm feeling.
Headache.
Patient
Loss of
suddenly
energy.
feels low.
Bloating.
Pregnancy-like symptoms.
Water retention.
So please unmute yourself.
Constipation.
What happens when we give somebody
Constipation.
done?
Muscle relaxant.
Most important is that there is sleepiness. Now I'd like to ask you, what happens in case you give somebody 𝐾𝐞10? Anyone? We all use 𝐾𝐞10, so?
Sir, sleeplessness.
All pharma people comes and pump in. They give you, madam,
It makes your brain active.
It makes the
Brain active.
When you take progesterone,
Alertness.
when you take progesterone, you go to sleep. When you take 𝐾𝐞10, you don't sleep. नींद नहीं आती है. You'll keep fighting with your husbands, scolding your children the whole night. You'll be activated. Or you keep working, keep watching Netflix the whole night. नींद ही नहीं आएगी. So how P4 and 𝐾𝐞10 works. That's the way I always. Hi Geeta ma'am.
Hi. I'm liking the word. Wife and husband go on fighting with having 𝐾𝐞.
People keep telling me, but people come and tell me, "क्या दवाई दे दिया?" My wife keeps fighting the whole night. Whole night. So what happens is that CoQ10 will activate you and progesterone will make you sleep. So try to give progesterone in the night, ho sake to, and give CoQ in the morning. So anyway, I'm very fond of talking and I keep talking. So just understand that every drug has got a way it is to be administered. Then shifting from helper cell types, this we all know, it modulates, it does immunomodulation, it inhibits, it reduces the bad interleukins, it will reduce TNF, and basically it make the uterus relax and bring more helper cells in the body so that the body can actually respond better to a pregnancy. And why does it happen? Can someone tell me the capacity of the uterus? Uterine capacity is how much? Uterine volume is how much?
5 to 7.
3 ml.
5
3
cc.
ml.
Normal
cc.
volume is
5 to 1.
5 cc.
5 to 7 cc, sir.
So 3 ml. I see some figure. And
0.5.
the volume of the uterus when the uterus is fully carrying a baby at term, how much?
900
1000.
I'll say minimum 5 liters. Minimum 5 liters with all the weight. So maybe more, maybe some less. But from 8 ml, 8 ml is going to become 5 liters. So uterus doesn't want to work. Why should it work? The uterus doesn't want to work. So to make the uterus relax in the whole process, body makes progesterone and 𝐿. So progesterone will maintain, do multiple things. It will improve the blood supply. It will cause the relaxation. It will make the uterus to sleep. It will actually put the uterus to sleep. Uterus so jata hai, so uterus cannot contract. In simple terms, just remember this. I know today I have very, very senior people with me, but still I like to say that in very simple terms that that's what progesterones do to the body. Along with this, it will lead to endometrial maturation, regulate inflammatory mediators, and it will lead to stabilization of the endometrium, blood supply, and this is in nutshell what does progesterones do to the body. And along with it causes sleepiness in the body, our body, the lady will go to sleep. I've tried taking a tablet of progesterone, you go into a trance, neend aa jati hai. I think all of you should try certain drugs. All of you should try taking AKT4 once. All of you take one packet one day. All of you should take progesterones and all of you should try CoQ and find the difference. So decreased progesterone levels or increase will lead to all these problems and they help in baby in implantation. Then they can cause immunomodulation by increasing the T helper cells, Th2 cells. I won't go into these basic things because they will confuse us more at this point of time. The topic is not about these things, but it can induce a blocking factor which we call as PIBF, and that will increase Th2 formation. So luteal phase deficiency, when there is no progesterone or progesterone is not sufficient, either it is not there or it is insufficient. Progesterone is important because it will make the endometrium secretory and allow normal implantation. This we know. So whether in case the quantity is low or average, it can cause a problem, and then progesterone receptors are not formed. And indicators of poor luteal defect, you'll find that there is a poor follicular growth. When the follicular growth is poor, number one, or there are multiple follicles forming. Either follicle kam bante hain ya bahut zyada bante hain, chote bante hain. We'll have less amount of, then we'll have a poor quality of corpus luteum. And when the corpus luteum is of a poor quality, we'll have poor endometrial, we'll have poor secretion of P4, and then we'll have poor endometrial response and low mid-level progesterone levels. This is what happens when we have a poor luteal phase defect. So luteal phase deficiency in ART, why does it occur? Now this is a very important thing. Why does it happen in ART? So ART means IUI and IVF both. So there are multiple things which can be covered, but these things are very important, but I'm not going to touch on these things. I'm going to touch about the luteal phase in ART. How does ART disrupt the luteal phase? And when you look at it, ART means IUI and IVF. So both the places we have to be quite careful about what we are doing. And this is an IVF cycle where we have IVF or we can have 𝐿H occurring. Here also we need to have good amounts of P4, and LH should always be having good pulsatile secretion. This you know. So moving ahead, same thing can happen in IUI also to some extent. So luteal phase deficiency in ART is about all about the COH, controlled ovarian stimulation, and luteal phase function. There's a correlation between the two. Whenever we do give somebody gonadotropins, or whenever we have more than 2 or 3 follicles in a woman, maybe in IUI, then in such case we should always give luteal phase support. So in an IUI patient, when we have only given letrozole, then in that case we need not give. In IUI, we don't recommend giving luteal phase support. And why, I'm going to come to that. So in a normal course of cycle, what happens? We have optimal. Now I want all of you who are with me, all of my friends who are here, all our students, just be with me for next 5 or 6 minutes. After that, it will be some cartoons and movies, but here I want you to be with me because this is what you don't know. This is also not taught by the people properly. In a normal course, we have an optimal follicular development. When we have an optimal follicular development, it means that there is adequate amount of estradiol, adequate amount of LH, good quality egg, adequate and good quality of corpus luteum, and corpus luteum secreting adequate amount of P4. So in such a case, when everything is normal, so LH and P4 mid-cycle is excellent. This you have to know. It's a normal course. Here we have 1 egg, 1 follicle or 2 follicles forming in a cycle. It's a natural cycle. But when we have controlled ovarian stimulation, here we say we are doing ovarian stimulation, and it can be controlled ovarian stimulation or controlled ovarian hyperstimulation, or we can have controlled ovarian stimulation. There are multiple terms. Then we have multiple follicular development here. Follicles which are formed are multiple in number. We are having a supraphysiological E2s. So here, see, 1 follicle which we normally discuss, the normal menstrual cycle we discuss for around 2 to 3 hours in all our lectures when we do it for our own people. But here you just understand that 1 follicle will make around 250 picograms of E2. 1 mature follicle of 20 millimeter. So when there are 10 of them, we'll have multiple follicles, and then we'll have around 2500 to 3000 picograms of E2. So here E2 goes very high, and when E2 goes very high, E2 will suppress the HPO axis. So when E2 will suppress the HPO axis, there would be very poor LH release and very poor quality corpus luteum forming, and whatever forms will go premature luteolysis. So this happens due to multiple follicular growth, and this is very important thing for all of you to understand. In ART cycles, whenever we do COH, these things are bad. Again, this I showed you for a single follicle, things are very, very good. But when we have multiple follicles, things starts going pretty bad. So when we have a large number of follicles, high amount of E2, poor quality corpus luteum will occur, and poor quality LH secretions will come from the body, and they will all alter the receptor dynamics, and there will be poor quality progesterone receptors in the endometrium, poor quality endometrial progesterone receptors in the corpus luteum also, and as a result, progesterone formation does not occur, and even the corpus luteum, then it will be receptive for implantation. So this is what the things which are occurring in an ART cycle, and so this is about what I've told you, that this is what I've already covered for you. Now one more thing occurs. When we are doing the pickup, we are aspirating the egg. So we also aspirate larger number of granulosa cells. So this we are also aspirating, and we're also causing a damage to the inner wall of the follicle. So in case this is a normal follicle, 2 layer, and there's an egg here, it ruptures egg goes out, and this is a very healthy wall is left here. But when we do the pickup by putting a needle inside, we will cause damage to the inner wall. As a result, the inner wall is gone and the follicle is of poor quality. But this is what we normally see. We got a long agonist, short agonist, and antagonist protocol. Luteal phase support is given in all the cases, and some cycles require more aggressive support, some require minimal support. Now this again, I like you to focus here. When we have a normal cycle, you look at this is a luteal phase. I want all of you to be with me. I have 200 people. I request all 200 of you to be with me for next 2 or 3 minutes more. After that, you may, sip your coffee or do anything, but now just be with me. Luteal phase is normally of 14 days. Now, when it's a normal cycle, it is of 14 days approximately. But in a hyper-stimulated cycles, it is cut short. It is cut short because of things which I have told you. And I'm going to send you this article right away after the class. So don't worry. Our concept is that when we teach you, we won't show you some slides and then walk off. We're going to give you all relevant literature also. This is important to know that luteal phase is cut short. And then the whole process today is how to build up this gap. Again, now look at this. Again, a nice, very nice. I'm going to send you the whole document in some time. When we have different type of, when we use different type of things, you'll find that we are having a cycle with GnRH analogs, and we have a cycle with GnRH antagonist and GnRH agonist trigger. We'll find that the E2 levels, the levels of P4 or the luteal phase support is very poor here. It's poor. It's also poor here, and it is okay here. So whenever we do a case with, when we do an intact cycle with an agonist trigger with lupride or decapeptyl trigger, the outcome is poor, very, very poor. So in such cases, normally we carry out frozen embryo transfer. So we have learned this when we have a poor luteal phase support, we have got poor follicle production, we have premature demise of corpus luteum, and we have poor uterine lining. This is very, very important. Normally people don't talk about uterine lining. This is important for you to know. The lining can go bad, and these all things can occur. I have already told you these things. So take home message 2, that when we carry out hyperstimulation, multiple follicles are formed. When we use GnRH analogs for trigger, and when we do the OPU, we will find that there is impaired corpus luteum. Corpus luteum is impaired, levels of P4 are less, and when the levels of E2 are very high, in that case, LH pulsations are very, very poor. So the supraphysiological E2s have to be controlled, and even if we don't control, we have to give a proper support later on. And somehow we get tired of it. After some time, what is this LH? What is P4? I'm sick of it. I don't understand it. So we say that go in for frozen embryo transfer. This will take away all your worries. This is what we are doing nowadays. But here also, you need progesterone support or LPS. LPS is more important in FPT cycles. So LPS you cannot actually escape. So luteal support in ART, how do we give it? What are the methods of giving luteal phase in support in ART? Well, let's look at it. I have around 20 more minutes of talk with you. Normally I talk for around 45 minutes and leave 15 minutes for discussion. So now coming to the drugs. LPS can be accomplished by these many drugs. So we have drugs like this. We can give 𝐿. So basically we have learned that poor corpus luteum means poor progesterone, and probably LH is also poor. But when there is an implantation occurring, the corpus luteum will make 𝐿. So 𝐿 will support the corpus luteum. So the thought comes to your mind that why don't we give 𝐿 only to the patient? Why don't we give only 𝐿 and maintain her? 𝐿 can be given. 𝐿 is a wonderful drug. But can someone tell me here, why do we avoid giving 𝐿 for luteal support? Anybody?
Hyperstimulation.
Risk of
For that,
OHSS.
corpus luteum should be healthy.
Risk of OHSS.
of OHSS.
Wow.
And
very
also corpus luteum should be healthy
healthy.
because HCG will stimulate corpus
Yes, ma'am. Perfect. So HCG,
luteum to produce progesterone. So it should be healthy and to prevent OHSS.
yeah, so HCG we're not giving. See, HCG, after we have a dinner, no? After we have a dinner, we have a 5-course dinner or a 6-course dinner. Then when we are leaving the restaurant, they give us some supari and pan to eat or some sort of things to eat. Chew, they give us mouth fresheners. So our 3 to 4 or 5-course meal will be actually progesterones in different forms. HCG can be added in a very small amount depending upon what type of case we are handling. It'll be like a mouth freshener, but it can never be like the whole meal. Don't you use HCG as the main course. Use it like a mouth freshener. You may add some amount of HCG later, which I've never added in my life, ever. I'm not convinced about that, but many people add. So progesterones can be given oral, it can be given intramuscular, it can be given subcutaneous, it can be given vaginal. These are a few routes of progesterone. See, all the hormones we normally give on the skin. Can we add progesterone? Can we have a transdermal progesterone or not? Why?
No, we cannot have.
Why can't we have? Why are we giving the woman? See, estrogen we are giving her on the skin, transdermal. We're giving her, see, we give every day nowadays. I'm giving those which you all would be giving androgens, lagaya, and 1% androgen we give for IVF. We're giving estrogen jellies. So we have got jelly of progesterone, we have got jelly of estrogens. Why not progesterones?
The action is supposed to occur on endometrium.
Yes.
Route of absorption may not be through skin.
Adequate levels in endometrium. We need adequate levels in endometrium.
It's oil-based and it causes dermatitis.
Okay, okay, very nice, very nice. Okay, great. So much for giving such wonderful answers. You all are right. But the right answer is that we don't give it because there is some enzymes in the skin which will degrade it within minutes. In case we keep P4 and it is being absorbed here on the skin, within minutes it will be degraded in the skin only. I won't go to those cyprotron, acetate, and the other type of things which occur. We'll talk sometime else when we have time. But progesterones, in case we have to give, so in case we give androgen, so suppose this is a sanitizer I'm using. So the gel of estrogen comes like this, and normally we can just take and put it on our skin like this, and then we just rub it. Same thing with the progesterones, we rub it. Okay, this we are aware of this. But when we give, we do it with androgens and estrogens. But when we give progesterone, it is not one drop. You'll have to take a whole body bath. It is so quickly degraded in the skin that we can use it, but then we'll have to use a bucket to get 1 day of quota. There's a complete different mechanism around this. So just remember that progesterones are never given transdermal. Just remember this. Some people give GnRH agonists. They're fond of pumping in some agonists, some amount of 1 ml of leupride or 0.1 ml of decapeptide, and because it will give you an LH surge. It will give you an LH surge. So LH surge comes and LH is going to make the corpus luteum healthy. So some people use agonist every 3 weeks. Again, I don't know, like it. We have an average pregnancy rate at Birla Fertility of around 75%. We are having pregnancy rate, that's a beta SCG, not a take home. We have never used any of these exotic drugs. I basically go for pure progesterones. Estrogens have got a different purpose. We won't talk about them here. So the role of progesterones kahan se aate hain? First of all, they come from soybeans, they come from Mexican yam, and this is a natural progesterone which comes from these roots. And when it comes, it is in this form of progesterones. This is a progesterone molecule. So now what do? We take these yams or something like shakkarkandi, and I'm sure that you would have all had shakkarkandi, like a shakkarkandi we have, which we eat very commonly in India. So when we take this shakkarkandi and you put it in yam and you put it under ultraviolet light, it is put in ultraviolet light, so the molecule becomes rotated. So the molecule of progesterone becomes a retromolecule, and then it becomes dihydrogesterone or a retropolymer. Just remember that normally we are using natural micronized progesterones, but when it comes under, keep it in the UV light and we make some minor changes, it becomes synthetic molecule. And this is one molecule which we commonly call as dihydrogesterone, and we use it as dufestrone and we use it as dihydrobone. Again, I'm not talking from any company. So look at this oral preparations. We can have oral preparations like this, and or they can be oral natural micronized progesterones. Again, now I need 3 minutes for 4 minutes from all of you. You all are very qualified colleagues of mine, use it every day like water. But I am going to tell you some do's and don'ts. Just remember that oral progesterones, natural micronized progesterones, are never to be given orally. Orally kabhi bhi nahi dena. Tablet like a sustain or something which is being sold in the market, it is not meant to be given orally, and they tell you also. But I've seen so many people, do goli subah sham kha lo, two capsules subah sham kha lo, or there are now effervescent tablets. So one morning, evening orally. Never give it orally. It is a contraindication to give any progesterone, natural progesterone orally. In case you want to give it orally, you can give synthetic progesterones. And this is given in ideal dose of 10 milligram TDS. Don't forget this statement of mine. And this is a statement which is very, very important. The moment you give any natural progesterone orally, it will be absorbed it will be degraded by the gastric juices. So never give any progesterone orally until it is a synthetic progesterone, and that is dihydrogesterone. Now, natural micronized progesterones, as I've told you, is not to be given orally at all.
Not even the sustained release form.
It is never to be given. If you want to give, read the literature. Many people give, you give. But there is no FDA approved article at all about their efficacy till now. Orally dena hai to dihydrogesterone dena hai. That's all. Okay. Now coming to injectable. Injectable, many people give depot. Yes, depot can be given, but depot can be painful, and depots are not in the natural. They can have androgenic effect. Micronized progesterone oil-based can be given. We give it 100 milligram. I have again reverted back. I don't know. I had my pregnancy rate fell down for some time, so I have reverted back to intramuscular injections now. It's again touching 70% plus. It fell down initially. I stopped it midway for around 3 to 4 months. So micronized progesterone orally, I give it. We've got a high plasma concentration, and then we can give it natural micronized progesterone water-based. Is called something like which can give in the skin. It doesn't have much of effect. When you give it oil-based, it's very painful. A lady will have big lumps being forming in case we don't give it properly. Problems can be there, but it works well. The choice will be yours completely. And subcutaneous ones are something like 𝐿 or something which is of 25 or 50 milligram. They also work, and they are less painless. But I don't have very great experience with micronized aqueous progesterones. Vaginals are the best you can give, and vaginal se behtar kuch hai nahi hai. And vaginal can be given in forms of a tablet or a capsule, or it can be given in the form of a micronized gel, which comes as 8% gel, so 90 milligram per day. Or in case we give a tablet, it is 600 milligram per day. This is what we are normally giving it to the patients. So ideally, we should only give one support per patient. Only one support per patient should be given as per the guidelines, but normally we all add 2 or 3. I normally add 2 supports. I'm telling you what I do. You can do whatever you like, depending upon your situation, but I normally combine 2 type of supports in a patient. So oral, injectable, vaginal are the 3 options we have. Now come to this. How much money do we spend? Because when I try to teach people, it is not only about the whole physiology and pathology. Look at the pharmacodynamics. We have to keep our treatment good plus cheap. So I am always in favor of cheap IVF. So at Birla Fertility, we are doing the IVF for 1 lakh rupees, all inclusive. So I think if we take good decisions, the price can be worked out. If you take an oral tablet of dydrogesterone, it is around 628 rupees or 425 for brand 1 and brand 2. And we give 3 tablets. So each tablet is around 60 rupees INR approximately, or 40 rupees INR one day. And we're giving 3 tablets. So we spend around approximately around, I say 200 rupees per day. These are the prices from the one. I've taken the prices from the telephone. I mean, I have not spoken to the company. These are the Pharma-Easy or the other dashboard. I've taken the pricing. Subcutaneous is around 120 rupees. Look at 8% gel. It is a daily application, is around 189 rupees. You take 400 milligram of micronized progesterone tablets. The 1 tablet comes for 47 rupees. And intramuscular injection comes for 120 rupees. So what do we understand from this is that we have to keep our treatment cheap also. And I normally try to keep the whole package in rupees 200 per day. So 200 per day and for around 15 days is economical for the patient. So this also should be part of your consideration. Vaginal progesterones are messy, but very effective. This you just remember. IM are painful. So coming to oral natural micronized progesterone, someone said SR. So orally we normally give dydrogesterone only, which is synthetic. 20 to 40 milligram, they got a very, very good bioavailability. Natural micronized progesterone, oral, never to be given. Just remember this. What is a natural micronized progesterone? Progesterone comes in big balls when we get it from the yam. So in case we make these particles very small, the particle size is made very small, it acts better. So it is called natural micronized. So big molecule we have broken into small molecule. So we call it a micronized. Natural means it comes from the nature, natural form, and P means progesterone. So when you look at this is the progesterone which we have. Oral, vaginal, oral and synthetic. Oral not to be given. I repeat again and again. And this is after in case we subject it to ultraviolet light. It becomes retroprogesterone. You see the shape? It has become teda-meda. It's rotated on itself. So that is called retroprogesterone. It becomes retroprogesterone, and this is the way things happen. So now it becomes synthetic. And now you can use it orally. This is for oral administration. And this is for injectable, vaginal or rectal, and not oral. Injectable progesterones are of 3 types. I've just covered that. Oil-based are my favorite. Compliance is good, but painful. People have a lot of pain. So, and micronized progesterones, water-soluble aqua preparations are available now. So 50 milligram per day is the dose I advise to you. Don't use 25, though studies have said 25 is equal to 50. But I feel 50 is a better dose in case you use aqueous progesterones. Moving quickly ahead, vaginal progesterones are always our favorite. Maybe tablets, maybe gels, and you find that they act, we put progesterones here, they act locally. So beautiful. It doesn't go to the liver. It perfuses directly. It goes through the, in case you look at this, it goes through these venous channels. It goes physically up. It goes through the blood vessels, and it increases good amount of, there's a counter current transfer of progesterone from veins to the uterine arteries. So it works beautifully. So vaginal progesterones, I prefer 8% gels. Single dose, 90 milligram per ml. 90 milligram preparation is there, you can use this. So it acts very, very nicely. As you can see here, even after 3 to 4 hours, 5 hours, you'll find the whole of yellow dots is progesterone is there everywhere. So micronized is the best method to be given vaginally. Give it rectally, you can give it vaginally. It can be given in the form of a gel or a tablet, a capsule, an effervescent tablet, whatever you want to do. It works very, very nicely. So micronized progesterone, as I told you, that we have 90 milligram per day for gel and 600 milligram per day is what I normally advise to the people. Some people combine these two also. Some people combine intramuscular and vaginal. I combine intramuscular and vaginal.